Welcome to Global Medical Office Dialogues. There are many obstacles to transplantation for individuals living with kidney disease, ranging from barriers getting on waiting lists to organ rejection. In this episode of Dialogues, nephrologist Dr. Sumit Mohan, Associate Professor of Medicine and Epidemiology at Columbia University, joins us to discuss strategies to address inequities in access to transplantation and why transplantation remains a vital therapy option for people living with advanced kidney disease. Welcome, Sumit.
Thank you, Frank.
Maybe we should start a little bit with the question of organ availability. And why does the United States have a different organ discard rate than many other countries that have successful transplant programs?
That's a complicated question. So let me start with, we have the largest organ allocation system in the world, right? We have a multi-layer deceased donor allocation system that goes from, or at least used to go from local to regional to national. A large focus of the transplant system in the United States has been on trying to ensure that we have good outcomes post-transplant. What that has led to is a system where there is increasing selectivity and selection pressures in terms of who we transplant and which organs we use for transplantation. And so what that selection pressure essentially does is it creates this incentive to try to use the best organs for patients who are going to give us the best outcomes, as opposed to, so we're comparing organs against each other as opposed to looking at organs for the quality that they would provide a given patient, right? So it's changed the paradigm a little bit. And so it has made it easier for transplant centers to decline organs when they're offered to their patients, leading to their ability to be declined. And so when multiple centers decline an organ, it's not surprising that eventually it's going to end up getting discarded.
It's a complicated process to recognize that there may be some unintended consequences of how transplant centers are measured in outcomes and their interest in taking as many organs as possible, I would assume.
You're absolutely right. It is an unintended consequence. I think the idea that we want excellent outcomes post-transplant is not something anyone would argue with. But if you look only at one part of the process, right, it is going to create pressures on the other parts of the system in ways that we never anticipated. For example, we have a multi-step process that goes for somebody who's starting out on dialysis to getting to transplant. They have to be educated, evaluated, waitlisted. That entire process has no scrutiny. It's this complicated black box. And so when you focus only on one part of the system, the rest of the system has unfortunately taken a hit.
I would assume the waitlisting policies follow a similar tension where if you waitlist more patients and you're measured on outcomes and number of kidneys that are actually transplanted, my guess is there's also a tension in the performance metrics of the waitlist and the actual support of the program. Do you see any conflict there?
Part of this conversation around unintended consequences has been, how do we move away from looking at just an isolated post-transplant metric, right? And so this has been an ongoing multi-year debate. One of the proposals on the table currently is looking at waitlist mortality. Our fear is by introducing waitlist mortality into the kidney transplant system, we are going to discourage transplant centers from being open to waitlisting patients because they are now going to be faced with the regulatory burden of ensuring low mortality on their waitlist, which will create more selection pressures, which is likely to have some unintended consequences in terms of access to transplant. And while transplant centers don't have consistent selection criteria, while there remains this black box in terms of which transplant centers are using which criteria, I think this is going to get harder and harder for patients if we're not careful about what metrics we choose to use.
I agree with that. I've had some conversations with our head of transplantation, Dr. Ben Hippen, around whether there might need to be sort of the final wait list and then sort of the on-deck wait list, and this concept of potentially having a shadow wait list that brings people to a point where they're really ready, but they're not in that final pathway of expecting a kidney in the next few months. Just curious what your thoughts might be on that.
That probably already exists in a way that is not patient friendly. The way the transplant system is set up is people get referred to a transplant center, they get evaluated, get waitlisted. When you are on the waitlist, you only receive an organ offer when you are active. Patients frequently don't even know when they are inactive or active. There is this large gap of information in communication between patients who are on dialysis and waiting for a transplant versus patients who are active and have everything ready and are receiving organ offers. Even for those patients who are active and receiving organ offers, they are unaware of when they receive an organ offer and a transplant center declines it without telling them. The challenge there is now this shadow idea where transplant centers, instead of inactivating a patient, may do what's called an internal hold. So rather than inactivating them, turning off their active status, preventing that patient from receiving organ offers while they are recovering from a pneumonia or some sort of brief hospitalization, they're temporarily inactivated. So they're continuing to receive offers, but nobody's communicating that. And so that has just led to increasing inefficiency in the system. So we already have a shadow wait list. We're also holding many people responsible for ensuring that dialysis patients are referred and that we have a high prevalent population on the wait list. That is now going to collide head on with this waitlist mortality measure. And it'll be interesting to see how this plays out.
Let's shift gears for a few minutes and talk about organ availability and organ discard rates on the weekend and why you think there's a weekend effect that's been seen in sort of availability of organs. And let that dive into a discussion on the variability between various OPOs that we see across the country.
So this was a finding we had many years ago where we were looking essentially for this idea of when organs are discarded, is there a usable set of organs that we shouldn't be discarding, right? So that became a primary question. And as you can imagine, not surprisingly, some organs are not usable even after procurement, right? Either because they get damaged or there is some sort of injury during procurement or something happens during transportation. While I think some organs will need always to be discarded, the question became what proportion of the organs that were discarded in the US are actually usable? And so when you ask that question, one of the things that we had to try to do was to remove organ quality from the mix. One of the things that we tried to do was look to see if there were differences by day of the week, because we know more causes of death vary by day of the week. That's a well-known fact. And so what we found in this analysis was that as you approach the weekend, so organs procured on a Friday or a Saturday that would ideally be transplanted Saturday or Sunday, the risk for organ discard goes up by 20%, even after you adjust for organ quality. Now, I will say that, lots of people didn't really believe our findings to begin with, right? Not surprisingly, they were like, wait a minute, is this real? The phenotype of the lazy transplant surgeon doesn't exist, right? People become transplant surgeons because they like the adrenaline rush and they like working in the middle of the night. But it's a real phenomenon because we've also gone back and looked at organs that are used to see how successfully and how easily they're placed. So organs that are accepted for transplantation on the weekend, on average, require more offers before a transplant center is willing to accept them. So we go further down the wait list before we find the right patient to take those organs. So clearly there's an effect on the weekend. Whether that is a function of resources is unclear because actually we're finding that the larger transplant centers are more likely to say no. So clearly there's an effect. What the cause of that effect is unclear. But the cause of that effect on patients is very clear. And by that, what I mean is this. When we look at transplant centers across the US, there is a wide variation in the probability of transplant. So if I got on the wait list today, depending on the transplant center I got on, my probability of getting a kidney transplant within 3 years of getting on that wait list varies from 4% to 64%. It's an enormous amount of variation. It's a 16-fold variation, something that we wouldn't accept in any other aspect of medicine. And so the question becomes, why is that, right? So the common logic has been, there is a variation in the organ supply, that different OPOs are effective to different extents. And so that has contributed to this large variation in access to transplant even after you get on the wait list. And I would argue that that's not the case. When we look at transplant centers within a single OPO, right, single donation service area, you may find 7, 8, 9 transplant centers on occasion. So for example, New York City has 9 transplant centers in a 10-mile radius, essentially, in a single OPO. And the way the organ allocation system used to work, at least, was that organs made available within that donation service area by that OPO first, those transplant centers got first dibs. So those transplant centers technically all have equal organ supply. And yet there's a 7-fold variation in the probability of transplant with just those transplant centers. So it's not organ supply, it is transplant center decision making. And so I think it is important that we start to have greater transparency in how transplant centers make these choices. What is influencing whether they take an organ offer for a given patient or not? What's influencing whether they list a patient or not? So that our patients can make informed choices about which transplant centers they want to be listed at.
It's a governance issue that you're really talking about here. It's the governance of how a transplant center accepts or declines an organ. Is that decision-making strictly in the hands of the transplant surgeon? Is it a broader group? Does the patient themselves get a play in that particular decision-making?
It's a complicated process, but it's a very time-limited process, because if a center is going to say no to an organ, the clock's ticking and we need the next center to use that organ. So each center gets about 60 minutes to make a decision. It's a very quick decision. There is usually a defined person. In the vast majority of transplant centers in the US, it is the transplant surgeon. There are some large transplant centers that do have nephrologists taking organ call and making these decisions. And to be completely honest, given the time crunch, unless you say yes, patients don't find out about these organs in real time. If I, as a surgeon, accept an organ, then I have to call the patient, make them aware of the organ offer, have them say yes. If I'm saying no, we don't tell patients today. That's the norm. Are patients part of the decision making? They are to some extent. So when we look at high risk organs, or we look at hepatitis C positive organs, or organs for older donors, we have patients opt into those sort of less than ideal organs to begin with. But they're not part of that decision-making process subsequently, right? And so if a patient's preference changes, they aren't given the opportunity to think about what other options exist, right? And so what we've been proposing is this idea of asynchronous shared decision-making, this idea that patients should have a say, they should be made aware. We recognize that it's a complex decision that cannot be shared in real time. But I think there are ways that we can share the decision after the fact, help patients understand the choices that transplant centers make, and have them, be in agreement. And if it's not in keeping with their preferences, it creates the opportunity for a patient in their transplant center to communicate about what it is that they would have rather had happen.
Do you think there's an opportunity to create sort of preemptive preferences of patients into a series of categories? I'm a patient who may be interested in accepting a higher risk kidney because it's so important for me to get off of dialysis right now, or something like that. Is there a way that you could categorize patients in advance so that the surgeon or the team making that decision has information about what's acceptable or what's more likely to be acceptable to a patient given their current condition?
I think part of the challenge there has been kind of categorizing organ quality and trying to figure out how we do that. I think one of the things that we did several years ago now, the allocation system, was, as a broad system, we introduced a composite measure of organ quality with the idea that A, it would help decision making, and B, it would help us identify these less than ideal organs and have patients opt into them. The primary problem with this system right now is that it's a percentile ranking. So what ends up happening is I rank an organ not based on the benefit it brings patients, but relative to other organs, right? So if I have a less than ideal organ that is in the 90th percentile, yes, 90% of kidneys procured in a year are better than that organ. But for the right patient, it still represents an enormous survival benefit and an improved quality of life, right? And that gets completely lost in translation. Because what you're telling me is, if you go into a grocery store and say, you're looking for strawberries, and I say, you know what, 90% of the strawberries are better than the ones that I'm about to hand you, you're not going to pick them up. Even if they're perfectly fine strawberries and you're planning to have strawberries today and you're going to eat them up and you don't want them to last 4 days, right? And so that's kind of where we're at. We're making the wrong comparisons. And once we start making the wrong comparisons and we're not talking about value to patients, it's hard for patients to make those choices.
Do you think the transplant community is ready to actively have an honest conversation about that issue and begin to address it in the way they evolve policies?
I think so. I think there are several of measures afoot. There is an effort from HRSA and SRTR to relook at metrics in the way transplant centers are being measured, right? It's this effort called the Task 5, and hopefully we'll have early results from those conversations later this year. I think there is a general recognition that we need to take organ choices in the context of what it offers patients, thinking in terms of developing clinical decision support tools that help centers say, wait a minute, if I have an organ offered today and I'm declining it, I have to do it in the broader context of recognizing I have a bird in hand versus two in the bush, right? So a transplant center would say no to an organ with the idea that this patient is going to get a better organ in a relatively short time frame. And if that's not true, which it frequently is not, then saying no is the wrong answer, right? So we're trying to develop these clinical decision support tools to try to help people understand whether it makes sense for patients to decline the organ offer that you have in hand for them.
We do mathematical physiologic models, but there are probably also economic modeling tools that could be used to look at not the economics of this, but actually to look at it from the standpoint of where the greatest impact for the patient actually is. And there are probably techniques that exist. And I know that some of the economists that developed the paired organ availability and the paired donation rules have done some remarkable work on looking at how to model patient behaviors with regard to that. I just wonder if there isn't some opportunity here.
Oh, there absolutely is. The challenge has been, and this has been something that we've been working on for a couple of years now, is to say, can we develop a clinical decision support tool that lives using a model that allows us to predict, what is the benefit of this organ today versus whatever the next offer is, right? So in order to be able to do that, we need to model out when's the next offer going to show up, and the probability that that next offer is actually going to be better than the offer that you're getting today in terms of quality. So it's a complex problem, in part because the longer somebody spends on dialysis, the same quality organ, provides a smaller benefit. So those two are not independent variables. They tend to interact with each other. It is a complex math problem, but you're right, it's not an unsolvable problem.
What do you think the upcoming changes are to the organ allocation system, and what do you think we might see in just the near future?
The most recent allocation change is what we call the concentric circle or circular allocation, which is in order to remove geographic disparities and this idea that organ allocation is a function of where you live. The allocation system is moved from specific donation service areas to circles. In other words, meaning the closer somebody lives to a donor hospital, in a circular area as opposed to an arbitrary boundary, they get some priority points for that organ. So anybody who lives within 250 nautical miles of a donor hospital gets some additional points because it's easier to get that organ to them. This is a stepwise process to getting to the final goal, which is that everybody in the country will have what we call continuous distribution, which is equal access to all organs, We have to account for distance between where an organ becomes available and where the patient is, just because we have to physically move the organ from there to that patient. So there will always be some kind of scoring or priority for people who live closer to where the organ is. But the idea is these arbitrary geographic boundaries for regions and donation surveys will go away. The challenge here is that when we do this, the complexity of the system is going to dramatically increase. So in our first step, where we've gone through these circles, we've seen an increase in cold disease time. And then unfortunately, we've also seen a dramatic increase in organ discard. So what used to be a 1 in 5 discard rate, 20% discard rate, in 2021 has suddenly gone up to 25%, meaning that 1 in 4 organs are being discarded. That number is close in the earlier part of 2022, appears to be 27, 28%. That is really problematic from my view. It represents a large number of kidneys that are potentially usable and could be used to save lives, extend lives, improve quality of life for thousands of our patients. And so while we're making this move towards continuous distribution, we have to keep an eye towards utility of the organ supply and making sure we're good stewards of what is essentially an incredibly valuable but scarce resource.
It seems like there are opportunities for us to improve our preservation solutions, our opportunity to try to reduce the impact or mitigate the impact of cold ischemic time if you're going to try to make this broader distribution a reality and not discard a lot of organs.
Absolutely. I think the science is in its infancy, but I think the opportunity for improved organ preservation, reconditioning of organs are enormous, right? Xenotransplantation is another aspect of what I think people are excited about in transplantation today. But the opportunity for good science here is quite large.
While you bring it up, I want to cross two thoughts. One is inequities in transplantation are substantial, both predominantly with living donor transplants, and some of that is cultural, some of that's probably the system of care and other health equity related issues that we have in this country. But the opportunity of xenotransplantation really sets forth the potential that organ supply and organ availability could, decades from now, be fundamentally different than it is today. Just some thoughts about that from your perspective?
If xenotransplantation becomes a reality, which, with the heart transplant in Maryland, the kidney transplant both at NYU and UAB, I think this has been an exciting time. If we are able to cross that barrier and we no longer have quite as tight a organ supply system, it suddenly creates the opportunity to radically change what we are able to do for our patients, right? Radically change inequities in the system, because then we're not talking about a constrained organ supply system. And so there is no reason that anybody who needs an organ isn't able to get one. It's definitely an exciting development, and hopefully something that we'll see sooner than a decade away.
It'll be interesting to watch that field evolve and become part of a broader discussion, which will include ethical components to the discussion. It'll include issues around society and how we look at making life-saving treatments available, this being sort of the lead one for kidney disease. Any final comments just about how we've looked at the issues of inequity in access to transplant care and transplanted organs?
Inequity is a major concern. If you are going to have a kidney allocation system of any kind, whether it's xenotransplantation or humans and scarce resources, the fundamental cornerstone of any system is that people have to believe that it is inherently fair. And the minute people stop believing that a system is inherently fair, it stops working as intended. So as much as, I am disturbed by discard rates and the fact that, utility is a competing with equity, I think we can't let go of equity. That's the one thing I will say, that we need to make sure that equity remains a cornerstone of anything that we do and develop. That's one. The other pieces I will say that we have been quite effective at how we have moved on the equity scale. So starting from recognizing in the early 2000s, changing the way we prioritize based on how organs were matched, to the most recent changes in 2014, where we moved from allocation time starting when you add somebody to the wait list as opposed to when you started somebody on dialysis. That major shift was done with the primary intent of mitigating disparities, and it has been remarkably effective. So if you look at the most recent data, it looks like we've made tremendous progress on that front. It doesn't mean that we have completely solved inequities in kidney transplantation, but the extent to which we have been able to successfully narrow them down on the deceased donor transplantation side, I think gives me hope that we can do this right in other parts of both kidney transplantation, kidney disease more broadly.
Any final comments on your perspective of what some of the critical issues are around organ availability and transplant access to care before we finish?
I would say that this is an exciting time for kidney transplantation. I think there is broad recognition that it is the preferred treatment choice, that we've gotten to the point where patients do remarkably well. Long-term outcomes are improving very quickly. So I think the onus is on us as clinicians to make this more widely available to our patients, whether that means getting more people waitlisted, whether that means encouraging more people to become organ donor, living or deceased. And hopefully with xenotransplantation, if it's truly around the corner, hopefully that will be a real game changer for our patients.
My guest today has been Dr. Sumit Mohan. We've been talking about transplant care and organ availability and many of the aspects of this area of taking care of people with advanced kidney disease. Sumit, thank you so much for joining us today.
Well, thank you, Frank.